So think about this. If a patient breaks their arm, right, the x-ray shows a clean, jagged white line. It's totally binary. It is either broken or it is not.
Right. Very cut and dry.
Exactly. And the treatment is just as straightforward. You set the bone, you cast it, and you just, well, you wait. But when you step onto a psychiatric floor, that x-ray machine is completely useless.
Oh, absolutely useless.
Yeah. You're no longer looking at fractured radiuses. You are assessing invisible chemical storms in the brain or unraveling decades of generational trauma.
Right.
You're trying to decipher coping mechanisms that have just completely short-circuited.
And you have to do all of that while the patient sitting right in front of you is actively in the worst crisis of their life.
It's intense.
It really is.
Yeah.
I mean, it's the absolute definition of diagnostic muddy waters.
Mm-hmm.
There's no blood test for profound hopelessness, you know? There's no imaging scan that can quantify a hallucination.
Yeah, that's such a good point.
In psychiatric mental health nursing, the primary diagnostic tool, like the most vital piece of medical equipment in the room, is you,
Mm-hmm.
the nurse.
And that brings us to the mission of today's deep dive, because we are talking directly to you. Yes, you listening right now. You have exam 2 coming up for your psychiatric mental health nursing course, and we know exactly what is on the line here.
The pressure is immense. We know you're looking at a 90-minute clock, 55 to 60 high-stakes questions.
Just right.
Dense clinical case studies, and of course, those dreaded select all that apply questions that make literally everyone question their life choices.
They are the actual worst. So you've brought us a massive stack of study materials. We're looking at the exam 2 blueprint, Boyd chapters 11 through 23, the ATI text. And frankly, looking at this outline, it is a mountain of information.
It's a massive cognitive load. If you try to just memorize this as a list of independent facts, you will get completely lost in the weeds.
For sure.
So our goal today is to weave all these disparate concepts together. We're going to build a conceptual roadmap that connects the microscopic biology of the brain to the macroscopic realities of patient behavior.
We're going to start with the hardware, right? The neurotransmitters. And from there, we'll build your operational framework using the nursing process ADOPIE to manage acute safety crises.
Then we'll navigate the absolute minefield of psychopharmacology. We'll explore side effects that can turn a routine shift into a code blue.
We'll also look at how your nursing priorities have to shift drastically depending on whether your patient is a 15-year-old or an 85-year-old. And finally, we'll tackle the highest stakes assessments in this field, trauma and suicide risk.
And we're going to end by running you through 2 rapid-fire clinical case studies.
Yeah, so by the end of this deep dive, you won't just be recalling definitions. You are going to understand how to think critically and rapidly, like a veteran psychiatric nurse.
Let's get right to the foundation then. Because you can't troubleshoot a computer network if you don't understand how the routers communicate, right?
Right.
In the human brain, those routers are neurons, and the signals are neurotransmitters.
And the exam blueprint puts a super heavy emphasis on these chemical messengers. I want to approach this clinically, though. Like if I'm looking at a test question about an SSRI, a selective serotonin reuptake inhibitor, I know it targets serotonin.
Okay, good start.
But the exam isn't going to just ask me to identify the acronym. It wants to know the actual mechanism. So walk me through the synaptic cleft. What is the SSRI actually doing down there?
Okay, so picture the gap between 2 neurons. That is the synaptic cleft. Neuron A is trying to send a message of mood stability to neuron B.
Okay, I'm picturing it.
To do this, neuron A releases serotonin into the gap. The serotonin floats across, binds to the receptors on neuron B, and boom, the message is delivered.
Makes sense.
But the body is highly efficient. It doesn't want serotonin just lingering there forever. So neuron A has these little transport proteins that act like vacuum cleaners. They literally suck the serotonin back up to be recycled.
Oh, and that process is called reuptake.
Precisely. Now, in a patient with clinical depression, we assume there isn't enough serotonin being released to begin with. The signal is just too weak.
The signal is weak, and that vacuum cleaner is still sucking up whatever little serotonin is actually there.
Exactly. So an SSRI acts as a chemical plug. It physically blocks that reuptake transporter on neuron A. Because the vacuum is plugged, the serotonin that is released is trapped in the synaptic cleft.
So it just hangs out there.
Yeah, it continuously bumps into neuron B's receptors, which artificially amplifies and prolongs that signal of mood stability.
That makes perfect visual sense. Okay, let's pivot to a totally different presentation. Say I have a patient who is hyperventilating, pacing the halls, just in the middle of a severe panic attack.
Okay.
The provider orders a benzodiazepine. Now, I know this targets gamma aminobutyric acid. I've always thought of GABA as the brain's brake pedal, but how does a benzo actually press that pedal?
The brake pedal is a really great way to conceptualize it. When a patient is in a state of acute panic, their central nervous system is just in overdrive. Excitatory signals are firing relentlessly.
Like pushing the gas all the way down.
Yes. Now, GABA is an inhibitory neurotransmitter. When GABA binds to its receptor on a neuron, it opens a channel that allows negatively charged chloride ions to flood into the cell.
Okay, and what does that do?
It makes the neuron hyperpolarized, which means it becomes highly resistant to firing. It essentially shuts the neuron down.
So wait, does the benzo just add more GABA to the brain?
Actually, no. That's a super common misconception. Benzodiazepines do not act as GABA, and they don't produce more of it either.
Oh, really?
Yeah. Instead, they bind to a specific accessory site on the GABA receptor. When the benzo binds there, it essentially supercharges the GABA that is already naturally present.
So it's an amplifier.
Exactly. It makes the receptor much more sensitive. So when native GABA binds, that chloride channel opens wider and stays open longer. The brake pedal gets pushed straight to the floor, forcing the entire central nervous system to rapidly decelerate.
Wow. Which is why benzos are so incredibly effective for acute anxiety.
Right, but it's also why they carry such a high risk for profound sedation and respiratory depression if you mix them with other depressants like alcohol.
That distinction is so crucial for a pharmacology question.
Yeah.
Okay, let's talk about MAOIs, monoamine oxidase inhibitors. These always trip me up. If an SSRI is a plug in the vacuum cleaner, what is an MAOI doing? Is it just like a much stronger plug that blocks multiple different vacuums?
No, it's a completely different mechanism of action.
Yeah.
Monoamine oxidase is an enzyme. If you want to use an analogy, imagine monoamine oxidase is a Pac-Man. It just swims around the central nervous system.
Okay, Pac-Man.
Yeah, and its biological job is to hunt down and destroy free-floating monoamine neurotransmitters, specifically norepinephrine, dopamine, and serotonin, just to keep their levels in check.
So it's essentially a demolition crew.
Exactly. In some severely depressed patients, we need to drastically increase the availability of those three specific neurotransmitters. So we give them an MAOI, which binds to the Pac-Man and completely neutralizes it. It inhibits the enzyme.
I see.
So with the demolition crew out of commission, the levels of norepinephrine, dopamine, and serotonin all rise significantly.
But because it's a blunt instrument affecting three major neurotransmitters all at once, it's incredibly dangerous, right? This is where those infamous tyramine dietary restrictions come in.
Yes, that is the primary clinical danger of MAOIs. And honestly, it is universally tested. Tyramine is an amino acid that regulates blood pressure. It's found heavily in aged, fermented, or cured foods.
Like aged cheeses, smoked meats, certain wines, draft beer.
Right. Normally, monoamine oxidase in the gut breaks down excess tyramine. But if you inhibit that enzyme with an MAOI, tyramine builds up to toxic levels. It displaces norepinephrine from nerve terminals, causing a massive sudden vasoconstriction.
And the patient goes into a lethal hypertensive crisis.
Yeah.
So the nursing priority there is intense dietary education. The patient has to know that eating a charcuterie board could literally cause a stroke.
And you must assess their cognitive ability and their willingness to adhere to that diet before an MAOI is ever even prescribed.
Okay, let's round out the neurotransmitters with the anti-epileptic mood stabilizers, like valproate or lamotrigine, which are heavily used in bipolar disorder. They target glutamate. Now, if GABA is the brake pedal, glutamate has to be the gas pedal, right?
That is the fundamental dichotomy of the central nervous system, yes.
Yeah.
Glutamate is the primary excitatory neurotransmitter. It facilitates learning, memory, and general neuronal activation.
But in conditions like bipolar mania...
Right. In mania, there's a massive dysregulation. The brain is literally flooded with excitatory signals. The gas pedal is stuck.
So how do the drugs fix that?
Anti-epileptic drugs work by inhibiting the release of glutamate, or by blocking its receptors entirely. They effectively cut the fuel line, bringing that dangerously high central nervous system excitation back down to a manageable baseline.
What fascinates me here is the bridge between this invisible cellular biology and the very visible behavioral crises that we manage on the floor. I mean, we are manipulating molecules to dictate whether someone has the cognitive organization to simply get out of bed or whether they are terrified by an auditory hallucination.
It's incredible, really.
But when you walk into a patient's room, you don't see a synaptic cleft. You see a human being in distress. You need a system to translate their behavior into a biological assessment, which is why the study guide heavily emphasizes the nursing process.
ADOPE.
ADOPIE. Assessment, diagnosis, outcomes identification, planning, implementation, and evaluation. It is the spine of all nursing practice.
But in acute psychiatric crises, the application of ADOPE requires a very specific, highly structured clinical lens.
Absolutely. Let's start with A assessment. In a med-surg unit, your assessment is largely physical. You're listening for crackles in the lungs, you're checking pedal pulses, measuring capillary refill. But in psychiatry, the primary tool is the mental status examination, or MSE. I like to think of the MSE as a mechanic running a full diagnostic systems check on a car.
That's a perfect analogy.
You aren't just looking at the paint job. You are systematically checking the alignment, the idle speed, the dashboard warning lights. Because if the patient tells me they feel perfectly fine, but they are pacing the room at 100 miles an hour, my diagnostic dashboard is flashing red.
The mechanic analogy is highly accurate because the MSE is entirely objective. It's about what you observe, not just what the patient reports. You systematically evaluate their general appearance. Like, are they disheveled? Are they wearing a heavy winter coat in the middle of July?
Which might indicate disorganized thought processes or poor thermoregulation secondary to schizophrenia, right?
Exactly. You're also checking the idle speed, their psychomotor activity. Are they exhibiting bradykinesia, moving with agonizing slowness, indicative of severe depression? Or are they hyperactive, demonstrating the psychomotor agitation common in acute mania?
And you assess their speech, too.
Yes. Is it pressured, rapid, and impossible to interrupt? Or is it poverty of speech, where they only give one-word answers?
You know, one area that consistently confuses students on exams is the difference between mood and affect. They sound like synonyms, but clinically, they are very distinct data points.
Oh, this is a classic exam trap. Mood is strictly subjective. It is the emotional state the patient self-reports. If you ask, how are you feeling today? And they reply, I feel like a dark cloud is crushing me. Their mood is depressed or hopeless.
Okay, so what is affect?
Affect is the objective, observable expression of emotion on their face and in their body language.
So if that same patient says, I feel like a dark cloud is crushing me, but they are smiling brightly and laughing while they say it, what's the finding?
You would document that their affect is incongruent with their mood. You might also see a blunted affect, where emotional expression is significantly reduced, or a flat affect, which is the complete absence of any facial expression.
Which is often a negative symptom of schizophrenia, right?
Exactly.
The MSC also assesses thought process versus thought content. And again, I feel like students really blur these lines. Thought content is what they are thinking, right? Like a delusion that the FBI is monitoring their thoughts.
Yes. But thought process is how they are thinking. You're evaluating the architecture of their thoughts. Are they logical and goal-directed? Or are they exhibiting flight of ideas, just bouncing rapidly from one unrelated topic to another?
What about circumstantiality? I always get that mixed up with tangentiality.
So circumstantiality is where they go on a massive winding tangent with excessive detail, but they eventually circle back to the original point. Tangentiality is where they go off on a tangent and never actually answer your question.
Oh, okay. That makes sense. So the MSE gives you the raw data to understand how the patient's brain is currently operating.
Precisely. So the diagnostic check is complete. Now we move to D&O, diagnosis and outcomes identification. This is where prioritization becomes quite literally a matter of life and death.
The study guide repeatedly emphasizes Maslow's hierarchy of needs, but in psych, physiological needs and safety needs seem deeply intertwined.
They are. If a patient is actively experiencing command hallucinations telling them to jump out a window, their physiological survival is the immediate problem. The nursing diagnosis would be risk for suicide or risk for injury.
And the outcome?
The outcome must be measurable, realistic, and time-bound. For example, the patient will remain free from self-inflicted injury throughout the 12-hour shift.
This actually brings up a really critical prioritization scenario. Let's say I'm the charge nurse. I have a patient in the day room who is yelling, throwing plastic chairs, and actively responding to terrifying internal stimuli. Their presentation is incredibly dramatic.
Okay, a high acuity situation.
But down the hall, I have a quiet patient with severe depression who has been silently collecting their plastic silverware from meals and hoarding it under their mattress. How does the ADOPE framework force me to prioritize my care here? Because honestly, my human instinct is to run straight toward the loud throwing patient.
And your instinct is reacting to your own autonomic nervous system. Loud noises and aggressive movements trigger our fight or flight response. The loud patient is disruptive, and yes, they require intervention. But ADOPIE requires you to evaluate the lethality of the threat.
Okay.
The yelling patient is externalizing their distress. The quiet patient is methodically planning an action with lethal intent.
So the hoarding patient is actually the higher acuity priority.
Without question. You have
Ouch.
to look at how acute psychosocial stress is activating the hypothalamic pituitary adrenal axis, the HPA axis.
How does that work?
When a patient is under severe psychiatric stress, the hypothalamus releases corticotropin-releasing hormone, which tells the pituitary to release ACTH, which tells the adrenal glands to pump out massive amounts of cortisol and adrenaline. The loud patient's HPA axis is driving a frantic fight response.
But the quiet patient.
The quiet patient is exhibiting a maladaptive, highly lethal form of emotion-focused coping. They have decided that the only way to escape the crushing psychological pain is to end their life. The rigid structure of ADOPIE forces you to look past the disruptive noise in the day room and address the silent, lethal threat down the hall first.
Wow, that is a really profound way to look at prioritization. It grounds you. So once we have our priorities straight, we move to P&I, planning and implementation.
Right. And the blueprint highlights specific evidence-based psychotherapeutic interventions here.
Let's break down CBT first, cognitive behavioral therapy.
CBT is one of the most rigorously validated interventions we have. It's built on the concept of the cognitive triad, which was originally developed by Aaron Beck. The triad consists of the patient's automatic thoughts about themselves, the world, and the future.
Okay, so in a state of severe depression, that triad is just completely warped. I am utterly worthless, the world is fundamentally cruel, and the future will only bring more pain.
Yes, those are cognitive distortions. The nurse's role in implementing CBT principles on the unit is to help the patient catch those automatic negative thoughts in real time, examine the evidence for and against them, and actively reframe them into more balanced, rational thoughts.
It's about breaking the cycle then, where a distorted thought leads to a depressed emotion, which leads to an isolating behavior, which then just reinforces the distorted thought.
Exactly.
Another framework mentioned is REBT, Rational Emotive Behavior Therapy, developed by Albert Bellis. This one uses the ABCDE model. Can you give me a clinical example of how a nursing student might actually experience this?
Sure, it's highly applicable to students.
Yeah.
REBT posits that it isn't the event itself that causes emotional distress, but rather the irrational belief about the event. The A is the activating event. Let's say you fail your first psych nursing quiz.
Okay.
The B is the irrational belief. Because I failed this quiz, I am fundamentally stupid, I will never be a nurse, and I'm a failure as a human being.
Ouch. I mean, I think we've all been there at some point. And the C.
C is the consequence. Because of that irrational belief, you experience profound anxiety, you stop studying, and you consider dropping out of the program.
So how does REBT fix that?
It focuses heavily on EDD, disputing that irrational belief. A therapist or a trained nurse will directly challenge that belief. Where is the evidence that one failed quiz dictates your entire future? Is it possible the test was just difficult, or your study methods need adjusting?
Got it.
The goal is to arrive at an effective new outlook. I failed a quiz, it is disappointing, but it is a data point. I will change my study habits and do better on exam 2.
It's much more confrontational than CBT, in a way, like you are actively attacking the irrational belief. Now, the third therapy listed is solution-focused brief therapy, or SFBT. This one stands out to me because it almost completely ignores the pathology.
It does. SFBT is highly pragmatic. It assumes the patient already possesses the tools they need to solve their problems, they just need help accessing them. The hallmark intervention here is the miracle question.
How does that work in practice?
You ask the patient, suppose that tonight, while you were sleeping, a miracle happens, and the problem that brought you to the hospital is completely solved. But because you were asleep, you don't know the miracle happened. When you wake up tomorrow morning, what will be the very first small change you notice that tells you a miracle has occurred?
What does that actually achieve, though? It sounds a bit like, I don't know, magical thinking.
It's actually a cognitive pivot. When a patient is in crisis, their brain is locked into a problem-focused state. They can only see the barriers. The miracle question bypasses the problem entirely and forces the brain to vividly imagine the solution state.
Oh, I see.
If the patient answers, well, the first thing I'd notice is that I wouldn't feel terrified to get out of bed and I would make myself a cup of coffee,
Yeah.
the nurse now has a concrete behavioral goal to work toward. Okay, how can we work on getting you out of bed for coffee tomorrow? It builds momentum from small, achievable steps.
That's brilliant. So we've assessed, diagnosed, planned, and implemented. The E is evaluation, which is continuous. Are the interventions working? Are the vital signs stable? Is the cognitive triad shifting?
Exactly.
But evaluating outcomes gets incredibly complicated when the treatment we implement, specifically psychopharmacology, creates a brand new medical emergency. The exam is going to heavily test our ability to recognize severe adverse reactions. We really need to spend significant time on antipsychotic side effects.
This is non-negotiable knowledge for the exam. First-generation typical antipsychotics like haloperidol or chlorpromazine are potent dopamine receptor antagonists. They block dopamine primarily in the mesolimbic pathway to stop the positive symptoms of schizophrenia, like hallucinations and delusions.
But dopamine doesn't just live in the mesolimbic pathway, it's also the primary neurotransmitter in the nigrostriatal pathway, which controls voluntary movement. So when you give a systemic drug that blocks dopamine everywhere, you get movement disorders.
That's exactly right. And the umbrella term for these movement disorders is extrapyramidal symptoms, or EPS. The study guide breaks these down into acute and chronic presentations. You must be able to differentiate the acute forms in a case study.
Okay.
The most terrifying for the patient is acute dystonia.
Walk me through what acute dystonia looks like on the floor.
It is a sudden, severe, sustained muscle contraction. It typically affects the head and neck. You might see torticollis, where the neck muscles spasm so violently the head is pulled severely to one side.
Oh, wow.
The patient might experience an oculogeric crisis, where the extraocular muscles spasm and the eyes roll completely upward in the head, locking there. Or they might have laryngeal spasms, which can actually compromise their airway.
Yep, sounds horrific, and it happens rapidly.
It can happen within hours or days of the first dose. The nursing priority is immediate pharmacological intervention. You do not try to talk them down or tell them to relax. They physically cannot.
What do you give them?
You administer an anticholinergic medication like benztropine, or an antihistamine like diphenhydramine, usually intramuscularly or intravenously for rapid effect. The spasm will resolve very quickly once the medication hits the system.
Okay, that's dystonia. The next acute EPS is pseudoparkinsonism.
Right, and the symptoms are identical to idiopathic Parkinson's disease because the root cause, a lack of dopamine activity in the motor centers, is exactly the same. You will observe a resting tremor, often a pill-rolling motion in the fingers. You will see muscle rigidity, a stooped posture, and a slow, shuffling gait.
And the third acute presentation is akathisia. Now, I've always heard this described as the feeling of crawling out of your own skin. But clinically, how do I tell the difference between akathisia and a patient who is just experiencing worsening anxiety or agitation? Because if they are just agitated, a provider might want to increase the antipsychotic dose, right?
That is the ultimate clinical trap. If a patient has akathisia and you give them more antipsychotic, you pour gasoline on the fire. Akathisia is a profound, intolerable internal sense of motor restlessness. The patient physically cannot remain still. They will pace the halls endlessly, shift their weight from foot to foot, rock back and forth.
So what is the differentiating factor then?
That's a subjective report.
Yeah.
If you ask an agitated patient why they are pacing, they might say, "I'm terrified the walls are closing in," or "the voices are screaming at me." That's emotional distress driving the movement.
Okay, and the akathisia patient.
If you ask a patient with akathisia, they will often say, "I don't know why, but my legs just will not stop moving. I feel like I'm going to explode if I sit down." The distress is secondary to the physical compulsion to move. Akathisia is notoriously difficult to treat. We often use beta blockers like propranolol, or we have to switch to the antipsychotic entirely.
Wow, okay, those are the acute symptoms. But the study guide also highlights tardive dyskinesia, or TD, as a chronic issue.
Yes, tardive, meaning late appearing. This occurs after months or years of continuous dopamine blockade. The receptors essentially become hypersensitive.
What does it look like?
AD presents as involuntary, rhythmic, repetitive movements, primarily of the face, mouth, and jaw. You will see lip smacking, tongue protrusion, chewing motions, and sometimes choreoorthotoid movements, which are writhing movements of the limbs.
And the tragedy of TD is that it can be irreversible.
It often is. Even if you completely stop the offending drug, the dyskinesia may persist for the rest of their life. This is why vigilant nursing assessment is absolutely critical. We use standardized tools like the AIMS, the Abnormal Involuntary Movement Scale, every few months.
To catch it early.
Yes, we are looking for the very first subtle twitch of the tongue or lip, hoping to catch it and adjust the medication before the damage becomes permanent.
Okay, we've covered the movement disorders, but now we have to talk about the red alert life-threatening emergency, NMS, or Neuroleptic Malignant Syndrome. NMS and serotonin syndrome look really similar on paper. They both cause a high fever, they both alter mental status, they both affect vital signs.
Ah,
If I get a select all that apply question, how do I definitively identify NMS?
It comes down to muscle tone and reflexes. Let's look at the pathophysiology. NMS is a catastrophic reaction to massive dopamine blockade in the hypothalamus and the basal ganglia. The hypothalamus controls thermoregulation, so when dopamine is blocked there, the patient develops a sudden, dangerously high fever, hyperthermia,
Temperatures of 104, 105 degrees.
easily. You will also see profound autonomic instability, tachycardia, profuse diaphoresis, and blood pressure that swings wildly from hypertensive to hypotensive. But the hallmark defining characteristic, the buzzword you must look for, is lead pipe muscle rigidity.
blood pipe.
The muscles become uniformly stiff and unyielding. If you try to bend the patient's arm, it feels like bending a solid lead pipe. They become hyperflexic.
That's the differentiator. Because serotonin syndrome.
Exactly. Serotonin syndrome, which is caused by too much serotonin, typically causes hyperreflexia. The muscles are twitchy. You will see severe clonus, where the foot physically beats against your hand when you dorsiflex it. NMS is rigid, stiff lead pipe.
So if I recognize NMS, what is the immediate nursing implementation?
Stop the medication. That is the absolute first step. You hold the antipsychotic, then you initiate aggressive supportive care. You cool the patient down with ice packs or cooling blankets. You administer 5E fluids to prevent kidney failure from muscle breakdown. And you may prepare to administer medications that act as dopamine agonists like bromocriptine or direct-acting muscle relaxants like dantrolene.
Another critical, life-threatening pharmacological side effect mentioned in the study guide is agranulocytosis. This is specifically linked to the atypical second-generation antipsychotic clozapine.
Clozapine is a highly effective medication for treatment-resistant schizophrenia, but it carries a severe black box warning for granulocytosis. This is a rapid, catastrophic drop in white blood cells, specifically neutrophils. It effectively wipes out the patient's immune system, leaving them vulnerable to overwhelming, fatal infections.
So the monitoring requirements must be incredibly strict?
They're federally mandated. A patient cannot even receive a prescription for clozapine unless they are enrolled in a national registry. The nurse must ensure that the patient has blood drawn to check their absolute neutrophil count, or ANC, every single week for the first 6 months. If the ANC drops below a specific threshold, the drug is stopped immediately.
On the floor, what symptoms am I assessing for? Because you can't see an ANC count without a lab draw.
You are looking for the earliest signs of an infection that the body can no longer fight. The classic presentation is a sudden high fever and a severe sore throat. If any patient on clozapine reports a sore throat or flu-like symptoms, it is not a routine complaint. It's treated as an impending medical emergency until a CBC proves otherwise.
Got it. I want to touch briefly on stimulants, which are used primarily for ADHD. Medications like methylphenidate or amphetamines. What are the key nursing assessments here?
Because stimulants increase dopamine and norepinephrine activity globally, they ramp up the entire system. In pediatric populations, the primary nursing assessments are monitoring for severe appetite suppression and subsequent weight loss. You must track their growth curve meticulously, as chronic stimulant use can cause growth delays.
Sleep issues.
Yes, you also assess for severe insomnia, educating parents to administer the medication early in the morning, never late in the afternoon.
Okay, let's pivot to antidepressants. The study guide highlights a specific FDA black box warning regarding SSRIs and other antidepressants. They carry a warning for increased suicidality in children, adolescents, and young adults under the age of 25. This feels entirely paradoxical to me. You are giving a medication designed to cure depression, and the warning says it might cause them to kill themselves. Walk me through the mechanism of that paradox.
It is a terrifying paradox, but clinically, it makes biological sense. When a young patient is in the absolute depth of a severe, major depressive episode, they often suffer from profound psychomotor retardation. Their energy is completely depleted.
Right, they can barely move.
Their cognitive triad is telling them that life is hopeless, and they may harbor intense suicidal ideation, but they physically lack the energy, the motivation, and the organizational capacity to formulate a plan and carry it out. The depression itself is acting as a paralyzing agent.
So they are essentially trapped by their own exhaustion.
Yes. Now, you introduce an SSRI. The neurovegetative symptoms of depression, the physical energy levels, the sleep patterns, the appetite, often respond to the medication much faster than the cognitive symptoms. The energy returns in weeks 1 or 2. But the cognitive distortions, the profound hopelessness, the desire to die, those might not lift for 4 to 6 weeks.
Oh, I see.
So you have created a highly dangerous window. The patient is still severely depressed and suicidal, but suddenly, thanks to the medication, they have the physical energy and the cognitive clarity to act on those thoughts. The paralyzing agent has been removed.
Therefore, the nursing priority is hypervigilance during that specific time frame.
Exactly. The risk of a suicide attempt actually spikes in the first 2 to 4 weeks of starting an antidepressant, or any time the dosage is significantly changed. The nurse must conduct rigorous, continuous suicide risk assessments during this window.
That perfectly illustrates a core theme of this material, the context changes everything. Giving that SSRI to a 20-year-old creates a massive paradoxical suicide risk. But if you give that exact same dose to an 85-year-old, you aren't nearly as worried about a sudden energy spike. You're worried about polypharmacy, drug interactions, and medication-induced delirium.
Right. The underlying biology of the synapse stays the same, but the developmental stage of the patient changes the entire nursing priority.
Which brings us to lifespan development.
Understanding developmental psychology isn't just academic background. It dictates how you communicate with your patient and what behavioral risks you prioritize.
The blueprint lists a few foundational theorists. Freud has mentioned the oral, anal, and phallic stages, which establish that early childhood experiences shape unconscious adult behavior. Piaget is listed, specifically his formal operational stage, which begins around age 12.
Piaget is critical for adolescent nursing. The formal operational stage is when a child transitions from concrete, black and white thinking to abstract reasoning. They begin to understand hypothetical situations, complex morality, and future consequences.
So communication shifts.
Yes. If you're counseling a 9-year-old, you use concrete, immediate terms. If you're counseling a 15-year-old, you can explore hypothetical scenarios and abstract concepts of identity.
But the heavy hitter for the exam is Erik Erikson's stages of psychosocial development. Erikson believed that at every stage of life, we face a specific psychosocial crisis. How we resolve that crisis dictates our psychological health. Let's dig into a few key stages, starting with infancy.
From birth to roughly 18 months, the crisis is trust versus mistrust. The infant is entirely dependent on caregivers. If the caregiver is consistent, responsive, and loving, the infant learns that the world is a safe, predictable place. They develop foundational trust.
But what if they experience severe neglect, abuse, or multiple chaotic out-of-home placements?
They fail to resolve the crisis. They develop profound mistrust. This isn't just a philosophical issue. It rewires their developing nervous system. They may develop reactive attachment disorder, where they are unable to form secure emotional bonds, or they may develop chronic baseline hypervigilance that manifests as severe anxiety disorders later in life.
Skipping ahead to adolescence, the teenage years, Erikson calls this identity versus role confusion.
This is a highly volatile stage. The primary task of a teenager is to figure out who they are as an individual, completely separate from their parents' identity. This striving for independence naturally leads to testing boundaries and high-risk behaviors, substance experimentation, reckless driving, unprotected sex. It is also a period of intense vulnerability to peer influence.
The study guide specifically highlights the psychological harm of bullying in this age group, as well as the compounding impact of adverse childhood events, or ACEs.
ACEs are traumatic events, abuse, neglect, witnessing domestic violence, having an incarcerated parent that occur before age 18. The data shows a direct dose-response relationship. The more ACEs a child has, the exponentially higher their risk for major depression, suicide, and substance use disorders in adolescence and adulthood.
When treating children and adolescents, the study guide makes it clear that the patient is never just the child. The patient is the entire family system. It mentions the use of genograms. How does a psychiatric nurse actually use a genogram on the floor? Is it just a family tree?
It's much more than a family tree. It is a clinical diagnostic tool. A genogram maps out at least 3 generations of a family, but it uses specific symbols to track medical history, mental illness, substance abuse, and the quality of relationships, who is estranged, who is enmeshed, where there is a history of domestic violence.
What does that reveal?
By mapping this out, the nurse can visually identify patterns of intergenerational trauma. It helps shift the perspective from what is wrong with this child to what has happened in this family system that is manifesting in this child's behavior. The primary goal of psychiatric interventions in childhood is family preservation, equipping the parents with psychoeducation so the child doesn't have to be removed from the home.
Moving into adulthood, Erikson defines young adulthood as intimacy versus isolation, and middle adulthood as generativity versus stagnation. What are the unique psychosocial stressors here?
For middle adulthood, the blueprint emphasizes the concept of the sandwich generation.
Meaning they are squeezed from both sides.
Exactly. These adults are simultaneously raising their own growing children while also taking on the caregiving responsibilities for their aging, declining parents. The financial, emotional, and physical demands are relentless. This chronic, inescapable stress leads us directly to the concept of allostatic load.
We briefly touched on the HPA axis earlier regarding acute stress. Is allostatic load related to that?
Intimately related. Allostasis is the body's natural, dynamic process of maintaining stability through change. When you encounter a stressor, your body releases cortisol and adrenaline to deal with it, and then it is supposed to return to baseline. But in the sandwich generation, or in anyone facing inescapable poverty or a high-stress career, the stressor never goes away.
So the HPA axis never shuts off.
Precisely. The system is chronically activated. Your body is constantly bathing in high levels of cortisol and inflammatory cytokines. Over time, this chronic overactivation causes profound biological wear and tear on your organs, your blood vessels, and your cellular DNA, specifically the shortening of telomeres.
That sounds devastating to the body.
It is. That accumulated damage is the allostatic load. It is the physical cost of chronic psychological stress leading to hypertension, cardiovascular disease, severe depression, and a compromised immune system.
So the nursing intervention here isn't just about handing out an antidepressant. It's about teaching aggressive stress management and differentiating between problem-focused coping, like hiring a home health aide for the aging parent to relieve the burden, versus emotion-focused coping, like drinking a bottle of wine every night to numb the stress.
Exactly. You have to address the load, not just the symptom.
Finally, we reach older adults, Erickson's final stage. Ego integrity versus despair. Looking back on a long life with a sense of fulfillment and wisdom, or looking back with bitter regret. The study guide highlights a major diagnostic danger in this population: pseudo-dementia.
This is a critical area for misdiagnosis. As people age, there is a natural cognitive slowing and a higher risk for neurocognitive disorders like Alzheimer's disease. However, severe major depression in an older adult can closely mimic dementia. They present with profound memory loss, confusion, apathy, and psychomotor retardation. This is pseudodementia.
So an 80-year-old patient comes into the clinic. They are confused, moving slowly, and can't remember what they had for breakfast. The provider might just assume it's Alzheimer's because of their age.
And if they make that assumption, they miss a highly treatable, reversible depressive episode. The clinical differentiation is nuanced but vital. When you ask a patient with actual dementia a question they don't know the answer to, they will often confabulate. They will invent a plausible story to fill the gap in their memory, trying to hide the deficit.
But a patient with depression.
A patient with depression experiencing pseudodementia will often just shrug and say, I don't know. They are aware of their cognitive deficits and are deeply distressed by them, whereas the dementia patient is often unaware. Furthermore, the onset of depression is usually relatively rapid over weeks or months, while true dementia is a slow, insidious decline over years.
We also have to be hypervigilant about polypharmacy in older adults. They may have a cardiologist, a rheumatologist, and a primary care doctor all prescribing different medications, and the compounding drug interactions can cause acute delirium.
Yes, and delirium is a sudden, fluctuating, altered mental status that is a medical emergency, not a psychiatric disease.
Absolutely. You also must assess the psychosocial impacts of aging, specifically sensory decline. Losing hearing and vision creates terrifying social isolation. When you combine social isolation with chronic pain and the loss of a spouse, you have a perfect storm. White males over the age of 85 have the highest rate of completed suicide of any demographic in the United States.
But the blueprint also includes the gerotranscendence theory, which offers a much more hopeful perspective on aging.
What does that theory suggest?
Gerotranscendence theory posits that healthy aging involves a fundamental shift in perspective. The individual moves away from a materialistic, rational, outwardly focused view of the world and transitions to a more cosmic, transcendent, internally focused view. They find profound meaning in quiet reflection, in nature, and in close, intimate relationships rather than external achievements.
So how does that change our interventions?
Nursing interventions shouldn't try to force an older adult to be as active and socially engaged as a 30-year-old. Instead, we should support this internal reflection through reminiscence therapy or life review exercises.
Before we move off lifespan and demographics, the study guide explicitly mandates the consideration of mental health disparities among marginalized populations, LGBTQ plus youth, racial and ethnic minorities, immigrants.
These populations carry an invisible heavy burden known as minority stress. This goes beyond the normal daily stressors everyone faces. Minority stress is the chronic, grinding, systemic stress of navigating prejudice, discrimination, systemic barriers to healthcare, and daily microaggressions. It significantly compounds their allostatic load and dramatically increases their vulnerability to psychiatric illness.
The required nursing response to this is cultural humility. I'll play devil's advocate here. Is cultural humility just an academic buzzword for being polite and culturally sensitive?
No, it is fundamentally different. Cultural competence, the older term, implied that you could read a textbook about a specific culture, memorize a list of traits, and suddenly become competent in treating them.
Which is pretty reductionist.
Very. Cultural humility is an active, lifelong commitment to self-critique. It acknowledges that you can never know everything about another person's cultural experience. It requires the nurse to actively examine their own implicit biases, the unconscious prejudices we all hold. Crucially, it means discarding the assumption that the Western allopathic medical model is the only valid way to view health and illness. It positions the patient as the expert on their own life and culture, and the nurse as a collaborative partner.
Understanding that cultural context, the accumulated allostatic load, the age-specific stressors, all of this data feeds into the most terrifying, high-stakes assessment a psychiatric nurse will ever perform. Evaluating when all of those compounding pressures finally push a patient past the brink of survival. We are moving into the assessments for suicide risk and violence.
This is where clinical hypervigilance is paramount.
Let's start by clearing the air. There are deeply ingrained societal myths about suicide that routinely appear as distractor options on exams. Let's debunk them. Myth number 1. Asking a patient directly about suicide will plant the idea in their head or push them over the edge.
This is a dangerous, completely false myth. Asking directly and plainly, "Are you having thoughts of killing yourself?" does not cause suicidal behavior. The data shows that it almost universally brings immense relief to the patient. They are carrying this terrifying, isolating secret. When you ask directly, you signal that you see their pain, you are not afraid of it, and it is a safe space to discuss it.
Myth number 2. People who talk about suicide or make superficial cuts are just seeking attention. They aren't in real danger.
Fact. Dismissing suicidal statements or self-harm behavior as attention-seeking is a lethal clinical error. The vast majority of people who die by suicide gave explicit verbal or behavioral warning signs beforehand. Every statement, every action must be taken with absolute seriousness. If they are seeking attention, it is because they are in agony and desperately need intervention.
Myth number 3. Suicide only affects people with a documented history of severe mental illness, like schizophrenia or chronic major depression.
Fact. While major psychiatric disorders are significant risk factors, many people who die by suicide do not have a known mental health diagnosis. An acute, catastrophic situational crisis, the sudden loss of a child, impending financial ruin, or public humiliation can trigger a highly impulsive, fatal suicide attempt in someone with absolutely no prior psychiatric history.
So if those are the myths, what are the evidence-based risk factors we should be looking for in a chart review? Why is a previous suicide attempt considered the single most highly predictive risk factor? I feel like human nature dictates that if you survive something that horrific, you would be less likely to try again.
That assumes the brain is operating under normal, rational self-preservation parameters. But the study guide references Thomas Joiner's interpersonal theory of suicide, specifically the concept of acquired capability. Humans possess a deep biological, hardwired instinct for survival. Attempting suicide requires overcoming a massive, terrifying psychological and physical barrier.
And once they cross it,
Once a person has crossed that line, once they have made an attempt and survived, they have acquired the capability. They have become habituated and desensitized to the fear and the physical pain of death. The barrier is permanently lowered, making a future attempt exponentially easier to initiate.
that is chilling, but it makes perfect sense. What are other major risk factors?
A family history of suicide, which carries both genetic and learned behavioral risks. Active substance abuse, which removes inhibitions and increases impulsivity. Profound social isolation. A pervasive sense of hopelessness, the absolute belief that things will never improve. And critically, sudden access to legal means, such as the recent purchase of a firearm.
On the flip side, we assess for protective factors. Things like strong connectedness to family, effective problem-solving skills, and religious or cultural belief that strongly discourage suicide. But the key takeaway is that protective factors do not cancel out risk factors. They simply help mitigate them.
Exactly. A strong religious belief does not make a patient immune to suicide if their acquired capability and hopelessness are high enough.
When it comes to actually conducting the assessment on the floor, the gold standard tool is the CSSRS, the Columbia Suicide Severity Rating Scale. Walk us through how a nurse utilizes this specific tool.
The Columbia scale is brilliant because it is structured as a logical escalation. It starts broad and narrows in based on the patient's specific answers, quantifying the lethality. You start with question 1. Have you wished you were dead or wished you could go to sleep and not wake up?
This is assessing for a passive wish for death.
Correct. No plan, just the desire. Question 2 moves forward. Have you actually had any thoughts of killing yourself? This assesses active suicidal ideation. If they say no to question 2, you skip to the end. But if they say yes, you must proceed to question 3. Have you been thinking about how you might do this?
Now we are assessing the method. Pills, hanging, firearms.
Yes. Question 4. Do you have these thoughts and have some intention of acting on them? This is the critical threshold of intent. A patient might have thoughts and a method, but say, I would never actually do it because of my kids. That is low intent. But if they say, yes, I plan to do it, you move to question 5. Have you started to work out, or do you have the details of how to kill yourself? Do you have a specific plan?
Wish, thoughts, methods, intent, plan. It systematically builds a complete picture of lethality. Now, for public health nurses or school nurses who are doing case finding in the community, the study guide mentions the IS-Path-WARM mnemonic.
Yes, this is a tool to identify warning signs in real time. Ideation, substance abuse, purposelessness, anxiety, trapped feeling, hopelessness, withdrawal from friends and family, anger or rage, recklessness, and sudden mood changes. If you see a cluster of these, it warrants a full Columbia assessment.
Okay, so you've completed the assessment. The patient is deemed high risk. We have to implement safety planning. I know that historically, psychiatric units used no suicide contracts. The nurse would literally have the patient sign a piece of paper promising they wouldn't hurt themselves.
Yes, and modern evidence-based practice has completely abandoned them. No suicide contracts are utterly ineffective. They do not prevent suicide. All they do is create a false sense of security for the staff and a misplaced sense of legal protection for the hospital. If a patient is determined to die, a piece of paper will not stop them.
So what is the current standard of care for implementation?
We utilize a commitment to treatment statement, or CTS. Instead of focusing on what the patient won't do, it is a collaborative agreement focusing on what they will do. They commit to engaging in therapy, taking their medications, and communicating honestly with staff.
The blueprint also mentions the Stanley Brown Safety Planning Intervention. How does this differ from a contract?
A contract is a passive promise. A safety plan is a proactive, step-by-step, actionable roadmap. It is created collaboratively when the patient is calm. It identifies their personal, internal warning signs, like when I start pacing and feeling a tightness in my chest. It lists internal coping strategies they can do on their own, like listening to a specific playlist or practicing box breathing.
It gives them a toolkit.
Exactly. It lists social settings or specific people they can use for distraction. It lists family members they can ask for help. And finally, it lists professional agencies and crisis lines to call if the steps fail. It empowers the patient with a concrete plan of action to utilize when the executive functioning of their brain is hijacked by suicidal thoughts.
That makes profound clinical sense. Now, suicide is violence directed inward, but psychiatric nurses also face the very real risk of violence directed outward. Managing aggression and de-escalation is a major safety competency. The study guide frames violence by looking at the cycle of intimate partner violence, or IPV.
The cycle of violence is crucial for understanding how aggression builds. It typically involves 3 phases. First is the tension-building phase. There's minor friction, verbal abuse. The victim feels like they are walking on eggshells. This predictably escalates into the acute battering incident, the explosion of physical violence.
Followed by the honeymoon phase.
Yes. The abuser is overwhelmingly apologetic, buys gifts, promises it will never happen again, and the victim desperately wants to believe them. But the underlying issues are not resolved, so the tension inevitably begins building again. We see a similar rapid escalation cycle in agitated patients on the unit.
So let's put the nurse in that scenario. You have a patient in the hallway, the tension is built, they are pacing, their fists are clenched, they are shouting at the staff, their anger is rapidly escalating toward an acute incident. As a nurse, What do you physically do? How should you act in that moment to prevent violence?
What's fascinating here and what is frequently tested is how the nurse's own implicit bias, physical posture, and tone of voice can either act as a fire extinguisher or as a match. If you approach a highly agitated patient squarely, standing chest to chest, making intense, unbroken eye contact, and using a loud, authoritative, commanding voice, you are instantly triggering their biological fight-or-flight response.
You are acting like a predator. You are a threat.
Exactly. In the animal kingdom and in the human brain, that posture is a challenge. De-escalation requires the exact opposite approach. You must project calm control. You stand at an angle to the patient about 45 degrees, never squarely in front of them. You maintain at least 2 arms lengths of distance to respect their personal space. You keep your hands visible, open, and relaxed by your sides.
And what are you doing verbally?
You maintain a neutral, soft, slow voice. You do not argue facts or logic, because an agitated brain cannot process logic. You validate their emotion. I can see that you are incredibly angry right now. It must be very frustrating to feel like you aren't being heard.
You align yourself with them instead of against them.
Yes, and you absolutely avoid power struggles. You don't say, you need to calm down and go to your room right now. Instead, you offer concrete, simple choices. Would you like to walk down the hall with me to stretch your legs? Or would you prefer to sit in the quiet room for a few minutes and have some water? Giving them a choice restores a small sense of control, which is usually what they're desperately fighting for.
What if de-escalation completely fails? The exam will likely ask about the use of physical restraints or seclusion rooms.
The rule for the exam, and for actual practice, is that restraints and seclusion are the absolute last resort. They are highly traumatic for the patient, they carry a significant risk of physical injury or death from asphyxiation, and frankly, they represent a failure of the therapeutic environment.
So when are they actually used?
They are never used for staff convenience or as a punishment. They are only legally and ethically permissible when there is an imminent, severe, and immediate threat to the physical safety of the patient or others. And all other less restrictive interventions like verbal de-escalation, offering PRN medications, or decreasing environmental stimuli have completely failed.
We have covered an immense amount of clinical ground. We started at the microscopic level with neurotransmitters in the synaptic cleft. We scaled up to understand how the ADOPIE framework structures our clinical thinking. We navigated the treacherous pathophysiology of EPS, NMS, and a granulate cytosis. We looked at how development across the lifespan completely alters patient presentation, and we tackled the heavy realities of suicide assessment and physical de-escalation.
The knowledge base is solid, but nursing exams do not test raw knowledge. They test clinical judgment. They want to know if you can synthesize all of this data when the alarms are sounding.
Which means it is time to take off the training wheels. We are moving into our final segment, synthesis. We are going to apply everything we just discussed into 2 rapid-fire, complex clinical case studies. This is exactly the kind of critical thinking you will have to execute on exam 2.
Let's run the scenarios.
Case study 1. The suicidal client hoarding medications. Here is the scenario. You are the nurse on an adult inpatient psychiatric unit. You are caring for a 35-year-old patient with severe major depressive disorder. They were admitted 48 hours ago after presenting to the emergency department with a highly detailed lethal suicide plan. They have a history of 1 previous suicide attempt 5 years ago.
Okay, let's walk this through the ADOPIE framework. First is A, assessment. At the start of your shift, you sit with the patient and utilize the CSSRS. The patient has a flat affect. They admit they still have active thoughts of wanting to die. The ideation is present. However, they deny having a current plan or intent while on the unit. Their previous attempt is a massive red flag indicating acquired capability.
But the assessment doesn't stop with the interview. Later that morning, during the medication pass, you hand the patient their prescribed SSRI and a multivitamin. You give them a cup of water, they take a sip, but as they turn away, you observe the patient cheeking the pills, hiding them in the buccal cavity of their mouth instead of swallowing them.
This is a critical behavioral assessment. We move to DANO, diagnosis and outcomes. The diagnosis is absolutely clear: risk for suicide. The cheeking behavior strongly indicates an active, methodical plan to hoard medication for a lethal overdose. The outcome identification is straightforward. The patient will maintain physical safety and remain free from self-inflicted injury throughout the shift.
So, P&I planning and implementation, the exam will ask for the priority nursing action. What do you do?
The absolute priority is immediate physical safety. You do not schedule a therapy session to discuss their feelings about the pills. You must instantly escalate their observation level. You initiate one-to-one continuous direct observation. A staff member must have unbroken visual contact with this patient 24 hours a day, 7 days a week, including when they're using the bathroom or showering.
What about the medication administration process itself?
For every future med pass, you must physically check their mouth. Under the tongue, the roof of the mouth, the cheeks. You may need to request the pharmacy change the medications to liquid formulations to completely eliminate the possibility of hoarding.
And what about their environment? They have been cheeking pills. We have to assume they already have a stash.
Yes. You must immediately search the patient's room and all of their personal belongings to locate and remove any hoarded pills or other lethal means. Crucially, unless the patient is actively violent, you perform this search with the patient present, explaining exactly why you are doing it, to maintain a therapeutic alliance and show respect. Furthermore, you ensure they are not assigned to a private room. Isolation severely increases the risk of a successful suicide attempt. They need a roommate and a room close to the nursing station.
Finally, EVA evaluation.
You are continually evaluating the safety of the environment, monitoring their mood and affect, and continually reassessing their suicidal ideation using the CSSRS at every shift change.
Excellent breakdown. Safety trumps everything. Let's move to case study 2, the psychiatric emergency scenario. You are caring for a 22-year-old male who was recently diagnosed with schizophrenia. He was admitted for acute command hallucinations and was started on a typical first-generation antipsychotic haloperidol 3 days ago. Today, the mental health technician calls you into the patient's room because the patient has suddenly become highly confused, is not responding to his name, and is sweating profusely.
Assessment. You rush into the room. The patient is diaphoretic. Their hospital gown is soaked. You immediately take vital signs. His temperature is 104.5 degrees Fahrenheit. His heart rate is 135 beats per minute. His blood pressure of 180 over 110. You attempt to straighten his arm to recheck the blood pressure cuff, and you encounter severe, unyielding resistance. The hallmark, lead pipe, muscle rigidity.
Diagnosis and outcomes.
The diagnosis is a severe, life-threatening adverse medication reaction resulting from massive dopamine blockade, specifically Neuroleptic Malignant Syndrome, or NMS. The outcome is immediate physiological stabilization, reduction of core body temperature, and prevention of renal failure and cardiovascular collapse.
Implementation. The exam gives you 4 options. Administer Tylenol for the fever, orient the patient to reality, administer the next scheduled dose of haloperidol, or hold the medication and call the rapid response team. What is the absolute first thing you do?
You hold the medication. You stop the offending antipsychotic immediately. Do not give the next dose under any circumstances. Do not wait an hour to see if the fever breaks. Stop the drug. Then you activate the rapid response team or notify the attending provider immediately. This patient has crossed from a psychiatric crisis into a critical medical emergency. They require intensive care, cooling blankets, aggressive 5E hydration to flush the kidneys, and likely pharmacological interventions like bromocriptine or dantrolene.
And evaluation.
Continuous, minute-by-minute monitoring of vital signs, specifically evaluating for the resolution of the hyperthermia and the relaxation of the muscle rigidity over the coming days in the ICU.
So when we synthesize all of this, what is the ultimate takeaway? When you look at these case studies, the ADOPIE framework forces the nurse to act on the highest priority, which is invariably physical safety and biological survival, before ever attempting to address the underlying psychiatric disorder. You don't ask the hoarding patient about their childhood trauma in that moment. You check their mouth for pills. You don't try to use cognitive behavioral therapy on the NMS patient to help their confusion. You stop the dopamine blocker and cool their body down.
That is the essence of psychiatric nursing. It is a highly complex, incredibly delicate dance between offering profound, empathetic psychological support and maintaining rigorous clinical medical hypervigilance. You must be able to switch between the two in a fraction of a second.
We have been on quite a journey today. You now have the conceptual roadmap. You understand the mechanisms of the neurotransmitters, the rigid structure of the nursing process, the terrifying realities of adverse side effects, the nuance of lifespan development, and the absolute critical nature of safety assessments.
You have the knowledge base. When you sit down in that testing center, take a deep breath. Read the questions carefully. Look for the acute safety priority hidden in the distractors. Trust your assessments, and remember the mechanisms of action we unpacked today.
But before we officially sign off, I want to leave you with one final provocative thought. It's something the study guide touches on deeply regarding the patients, but we rarely apply it to ourselves.
Throughout this deep dive, we talked extensively about allostatic load, the profound biological wear and tear that chronic, unremitting stress inflicts on the body, the brain, and the cellular DNA. The study guide frames it as a patient issue, explaining why the sandwich generation develops hypertension, or why minority stress leads to severe depression. But I want you to realize that this concept applies equally to you, the psychiatric nursing student and soon-to-be nurse.
Nursing school is the definition of chronic stress. The exams, the clinicals, the constant pressure to perform flawlessly.
And psychiatric nursing specifically is a unique crucible. In this specialty, you do not have surgical instruments. You do not have ventilators. You are the primary therapeutic tool for a human being who is currently experiencing the absolute worst, most terrifying crisis of their life. You are routinely absorbing their trauma. You are managing their aggression. You are maintaining constant, exhausting vigilance to keep them alive. It is incredibly heavy, profound work.
Which means your HPA axis is going to be activated. A lot.
Yes. If you do not actively manage your own allostasis, if you do not practice your own rigorous stress reduction, if you do not continually confront your own implicit biases, and if you do not fiercely protect your own mental and emotional health, you will accumulate a massive allostatic load. You will physically and emotionally burn out before your career has even truly begun.
It's the oldest cliche, but it is a biological fact. You cannot pour from an empty cup.
Exactly. To be the expert, empathetic, vigilant psychiatric nurse that these vulnerable patients so desperately need, you have to survive the process intact. You must treat your own stress with the same clinical seriousness that you treat a patient's. Protect your peace as fiercely as you protect your patients' lives.
I think that is the perfect place to end. To our listener, take a deep breath. You have put in the work. You are highly prepared for exam 2. Keep questioning the material, keep learning the why behind the facts, and above all, trust your clinical judgment. You've got this. We'll see you on the next deep dive.